I think we should start. Good morning, good afternoon, good evening, everyone, wherever you're joining us from. And welcome to another series of webinars organized by the International Institute for Primary Healthcare. And today we have a very special webinar for you, organized with One Health Global Alliance on strengthening the multidisciplinary healthcare workforce to combat Marburg virus disease. This disease reminds us that outbreaks are not only biomedical events, but they're also a system-wide stress, and they challenge our surveillance, our labs, our infection prevention systems, as well as our emergency operations. And most of all, the people who hold these systems together across disciplines and institutions. So in today's discussion, it's all about how we can ensure that clinicians, public health professionals, lab technicians, and everybody in between can be better prepared to work as a one unit before, during, and after an outbreak. With that being said, I would like to introduce our moderator for today, Dr. Taqwa Morgu, who is a public health leader and policy strategist with extensive experience in advancing evidence-based solutions at the intersection of research, global health, and equitable policy. She's also a co-founder and chief operating officer at One Health Global Alliance, where she provides strategic and operational leadership across activities. And previously, Dr. Worku held roles at the U.S. National Academies of Science, Engineering, and Medicine, directing consensus studies and multiple stakeholder collaboratives, including the 2022 study on improving the CDC quarantine stations network response to emerging threats, an international study on rare disease drug regulations, and the national effort to establish a working definition of long COVID, and the action collaborative on engaging community practices and clinical trials. She has also worked at the Association of State and Territorial Health Officials, ASTO in short, supporting states and territories in advancing evidence-based public health strategies and strengthening clinical to community connections. Dr. Wargu holds a Doctor of Public Health and a Master of Public Health and is deeply committed to driving solutions that improve health outcomes for communities globally. It's my distinct pleasure to welcome Dr. Taqwa to moderate this session for us. Over to you, Dr. Taqwa. Thank you.
Wonderful. Thank you so much for the introduction, Dr. Abinet, and welcome everyone. It is my true pleasure to moderate this discussion on a very timely and important topic. And this webinar is titled Strengthening Multidisciplinary Healthcare Workforce to Combat Marburg Virus Disease Outbreaks. Like many countries, as you've mentioned, Ethiopia continues to strengthen its preparedness for infectious disease threats, including viral hemorrhagic fevers such as Marburg virus disease, and responding effectively to these events depends not only on system and infrastructure, but also on a well-prepared and multidisciplinary workforce. So this webinar will explore practical lessons learned from past and ongoing outbreak preparedness and response efforts, but with a particular focus on workforce readiness and partner engagement. Our goal in this webinar is to highlight what has worked well, identify areas for continued strengthening, and discuss how partners can best support coordinated and effective responses. So over the next 90 minutes, we'll draw on global experience responding to Marburg virus disease and other viral hemorrhagic fevers. We'll also review Ethiopia's current workforce readiness, including both strengths and areas for improvement. We'll also briefly explore the role of partners in preparedness and emergency response efforts in the context of Ethiopia, as well as other countries globally. And finally, we'll provide some space for you all to also participate by submitting your questions as well. Yes, throughout the session, I think for those of you that might not be familiar, you will be welcome to submit your questions using the Q&A function, which you should be able to find at the bottom of the Zoom screen. And we'll try to address as much as possible at the end of the session. And throughout the session, some of the speakers may respond directly using the chat function, but verbally we'll have a more open discussion at the end of the session. So with that, let's move on to our first session. And I think to set the stage, it's really important that we begin with a broader perspective. Marburg virus disease, it's not new, and the global experience particularly with viral hemorrhagic fevers, offers very important lessons for preparedness, response, and workforce capacity. And I am now pleased to introduce Dr. Ermias Balay, who serves as the Principal Deputy Director at the United States Centers for Disease Control and Prevention, and brings an extensive experience working on viral hemorrhagic fevers outbreaks across multiple regions globally. And I would like to just very briefly also note that Dr. Ermias is presenting today in his personal capacity and not on behalf of CDC. And with that, I will turn it over to you, Dr. Ermias, whenever you're ready.
Thank you. Thank you, Dr. Takwam. I'm testing my audio at the same time. Everything's good? All right. I'm going to start sharing my screen. Let me see if this is that working, Dr. Takwam?
Yep, we can see it.
Great, wonderful. Good afternoon to most of you. Good morning to those of you who are in the United States. I'm coming to you from the East Coast of the United States. As Takwam said, I work for the Centers for Disease Control and Prevention, but I'm not here representing my agency. I'm presenting this as my personal capacity. And I'd like to thank the organizers. It's a distinct pleasure for me to be able to address you about this important and fascinating disease, Marburg virus disease. Because time is very limited, I'll go through my slides very fast to try to leave ample time for questions and answers. I'm trying to advance my slides now. Okay, here is an outline of my talk for today. I will give a very brief overview of viral hemorrhagic fevers in general, then focus on Marburg virus disease, its clinical features, its diagnosis, the patient management, and I'll touch upon the properties of the virus. And I will highlight what I call key pillars of MVD outbreak management, the most important pillars that we should pay attention to. And then I'll conclude with a discussion on the natural reservoir for Marburg virus disease. So a little bit about viral hemorrhagic fevers. They are caused by several distinct virus families. I've just listed only a very limited number of them. There are a huge number of viruses that could be categorized as viral, causing viral hemorrhagic fever viruses. Viral hemorrhagic fevers. But I, again, as I said, I listed only a very small number of viruses on this table. Most of them require high-level biosafety containment, and mostly the BSL-4 or the top-level biosafety laboratories to manipulate them. If you look at the table on the left side, you see the virus family, and I gave examples of viruses in the middle and how they are spread or transmitted on the right side of the table. So if you take the first one, arenaviruses, a very good example in that virus family is Lassa fever. And as most of you know, that's spread by rodents or rats. And then as an example would be, another example would be Crimean Congo hemorrhagic fever, and that is spread by ticks. So you could see all the examples that I provided. But if you go down to the bottom, you come to filoviruses. A filovirus is the virus family that includes Ebola virus and Marburg. And those viruses are primarily spread by Egyptian fruit bat. And that's for Ebola, that's thought to be the natural reservoir. For Marburg, we know for sure that Egyptian fruit bats are actually the natural reservoirs for them. Now, a little bit about Marburg virus itself. It's an enveloped single-stranded RNA virus. It's primarily found in bats, as I've already said. And there are two viruses in that species. Marburg is one. The second one is what we call Raven virus. The two viruses are very closely related genetically, and both of them cause an illness that's indistinguishable clinically. So for all practical purposes, both viruses cause the same disease. In the virus, the Marburg virus can persist on surfaces, liquid or dried material, for days. So it could survive on surfaces for some time. But fortunately, it's very easily inactivated by boiling, for example, contaminated clothing, by treating it with bleach and common disinfectants used in clinical care settings, in healthcare worker, in hospitals and clinics. Now, all these properties of the virus are very critical for its transmission and also for inactivation. The fact that it's enveloped virus means it's very easily inactivated. The fact that it's an RNA virus, it's a very small virus. It has actually one of the smallest viruses we know. It only has 7 genes. But a virus that small, how efficiently it's transmitted in causing very serious disease is a very fascinating story. And that's because despite the fact that it's a small virus, which means it produces very limited number of proteins, those proteins serve multiple functions because each one of those, although they are small in number, because they serve multiple functions, that makes the virus very, very efficient in transmitting and also causing disease. Now, the disease that's caused by Marburg virus is Marburg virus disease. It has an incubation period of, on average, about 10 days, although it could range between 2 days to 3 weeks. The disease typically occurs in outbreaks, and it was, as you probably already know, first identified in Marburg, Germany in the 1960s, where it caused an outbreak among laboratory workers. Simultaneously, a similar type of outbreak was happening in the former Yugoslavia among laboratory workers. In these workers were exposed to African green monkeys that were imported from Uganda. And that's where the name Marburg comes from, because the first outbreak was detected in the city of Marburg in Germany. Since the 1960s, at least 18 outbreaks of MVD has been detected, almost exclusively in African countries, and we'll talk about why that is. The largest outbreak that was documented actually occurred about 20 years ago in Angola. In that outbreak, there were over 370 cases with a case fatality rate of about 80%. And that's the largest outbreak that has been documented. Now, this map shows the areas where the outbreak of MVD has been detected, primarily in the Central African countries and a couple of countries in West Africa. What you don't see on this map is South Sudan. There have been cases, and most recently, as you know, in Ethiopia. Now, the clinical features of MVD could be classified as happening in 2 stages. There's the very early stage, and this is related to the way the virus actually is replicating in the body. In the early stages, there's non-specific abrupt onset of fever, chills, fatigue, and myalgia. And as you can imagine, these are very non-specific symptoms and can mimic other febrile illnesses that actually are common in tropical regions. A few days later, we see what we call the wet stage, and this is the time when there's very severe diarrhea in the patients, and accompanied by a wide range of GI symptoms and respiratory symptoms that are listed on the slide. Although the name hemorrhagic is used a lot, bleeding is not universally detected in patients, but it could happen in a good number of patients, bleeding from different parts of the body, including the ones that I have listed on the slide. In the skin, when you inject needles in the patients, the bleeding doesn't stop. There's bleeding in mucosal membranes, and they may be bleeding in internal organs also. So the clinical manifestation is very distinct. Early on, very difficult to diagnose. In the initial phases of an outbreak, the diagnosis of MVD could be very, very challenging, primarily because it could be confused with other viral hemorrhagic fevers. It could also be confused with other diseases such as malaria, dengue, typhoid fever, diseases that are very common in areas where MVD has been detected. Now, laboratory confirmation is very critical, particularly, again, as I said, at the outset of the outbreak, and also for not just diagnosis, but for controlling the outbreak effectively. So having laboratory testing available close to where patients are is very, very critical, not only in diagnosing and taking care of the patients, but also controlling the outbreak itself. The most common way of confirming the diagnosis is by doing molecular testing with RT-PCR, but there are other tests that are available, particularly serology testing. But these particular serology tests are useful for survivors of MVD infection. Once patients survive, they may continue to harbor the virus in a very small number of patients. To be able to retrospectively confirm the disease, serology is very critical, and RT-PCR may or may not be useful at that time. Now, cell culture could be done, but because these are highly pathogenic organisms, their manipulation requires a BSL-4 facility. So cell culture should only be attempted in a very high containment laboratory. Now, MVD patient management. The management of patients is very non-specific again. It's primarily supportive. The patients lose a lot of fluid and a lot of bleeding in internal organs. For that reason, very aggressive IV fluid management, electrolyte replacement, and sometimes, if needed, blood transfusion would be very, very important. If the patients are very aggressively managed, the survival rate could be very high, particularly with blood transfusion and electrolyte management. What is critical is rapid diagnosis and rapid isolation of these patients. They should be treated in an isolated environment with very strict appropriate infection control procedures. These are very, very critical, primarily to protect healthcare workers, but also spreading within the healthcare setting to other patients. As a matter of fact, usually the first sign that MVD outbreak has occurred is detection of the disease in healthcare workers. Healthcare workers are at a very high risk if appropriate infection control procedures are not instituted. I cannot overemphasize that because protecting healthcare workers is very critical for the continuing management of patients, but also for the outbreak control. And we'll talk about that a little bit later. There's no approved treatment directed to the virus, and there's no approved vaccine. But there are a number of treatment modalities and different candidate vaccines that are still under investigation, but none of them have been currently approved for use in MVD. Now, Marburg virus, one of the characteristics of the virus is it replicates very, very rapidly. It invades multiple organs, and the virus is shed in pretty much any bodily fluid you can imagine would actually contain the virus, including the ones that I've listed on the slide. So the body fluids that actually potentially can spread the infection include saliva. It could be detected in sweat. It's been detected in vomit, and of course in diarrhea, urine. It's been detected in semen. So pretty much any bodily fluid that actually comes out of a patient infected with MVD is infectious. So as you can imagine, patients with MVD, I try to usually say are they radioactive. Viruses being shed pretty much through every body fluid that comes out of the patient. And again, this is very significant for the transmission and also for infection control. Why this much virus is shed from patients is also very fascinating, and I'll try to describe it in this next slide. We talk about a perfect pathogen. If there is a perfect pathogen, Marburg virus disease and Ebola virus disease would be a very, very good candidate. So sometimes I say there's a Nobel Prize for pathogens, they would be very good candidates, and I would explain why. Marburg viruses are known to replicate extremely fast in the body. And the reason is most viruses, as you know, are intracellular, and to get access into the cell, they require a receptor on the cell surface. But Marburg virus does not need receptors to get access into the cells. Without bogging you down into details, it basically forces itself into the cell without waiting for receptors. That gives it the opportunity to get into the cells very, very rapidly. Not only that, once it gets into the cell, it actually blocks the chemicals that signal our immune system into the presence of the virus itself. So once inside, it targets those molecules that signals the body's immune system to detect that intruding virus. Because it blocks that mechanism, the virus is now free to replicate without our immune system detecting it. And this happens for 24 to 48 hours. So the virus has ample time to replicate itself and spread to different organs within the body without being detected by the immune system. And the fact that the virus is very small actually gives it that opportunity or advantage to assemble itself very, very fast within the cell, because it's a very small number of genes that it should be assembled for the virus to become mature and then spread to other cells. And this happens, as I said, without our immune system detecting it for about 48 hours. Now, by the time our immune system, our immune defenses actually wake up and detect the existence of the virus has already spread to pretty much all the organ systems that you can imagine. Almost in a panic, our immune system then mounts a massive response, which we call a cytokine storm. And it's this massive response that actually damages the organs and is responsible for all the symptoms that you see in MVD. This massive immune response causes the blood vessels to become leaking. And because of that, the patients lose a lot of fluids and electrolytes, and sometimes also cause bleeding in many different parts of the human body. So very tricky virus. it in our immune system doesn't help. In fact, causes most of the symptoms that we see in these patients. Unfortunately, this creates a big problem for us public health workers because this disease transmits fast and actually damages the host. Some have argued, what's the advantage for the virus to cause this much disease and kill the host itself? Now, what it loses by killing patients, actually it makes up by replicating fast and transmitting from person to person so that the virus would maintain its cycle. Very fascinating disease. Now, MVD transmission, as you can imagine, as I indicated earlier, spreads in two different ways. One way is the direct transmission from Egyptian fruit bats that people may come in contact with. And once humans are infected, then it spreads very easily from person to person. Bodily fluids infected with patients or dead bodies. But we emphasize special handling for dead bodies because by the time MVD causes death in patients, that means the very, very high level of viral load in those dead bodies. So dead bodies are something to be very, very, very cautious about in terms of handling them. In other objects that are contaminated with fluids from these patients, the clothing, the bedding, needles, anything that contains the stool, the diarrhea that's coming out of these patients, the vomitus, all those bodily fluids, but also the environment that's contaminated by them could potentially be a source of transmission. One other thing that's unique about this virus is to cause infection, you need a very, very small number of viral particles. It's one of the viruses that causes disease with the smallest number of particles. You pretty much need less than 10 particles for Marburg virus to start causing disease. It's one of the lowest infectious doses that we know of. And as you probably already know, semen from patients who have recovered from MVD could potentially also carry the virus and transmit it. Prevention of MVD, avoid contact with blood and bodily fluids, avoid contact with semen, avoid contact with the natural reservoir, and be cautious in handling infected materials in taking care of patients. Very quickly, these are the key pillars for MVD outbreak management. Each one of them actually have their own guidelines, so we can go into a lot of details in describing each one of those pillars or key pillars for MVD outbreak management. But we don't have time to go through them, but I have provided resources at the end of the presentation. Early detection, very critical, not only for the patient, but also for preventing further transmission of the disease or the virus to other patients. Rapid isolation, not just isolation, but early detection and isolation is very critical. In an institution of infection control measures, contact tracing, we'll talk about it a little bit, very, very critical. Safe burial practices, as I say, dead bodies are very infectious. And most important, and the other key pillars would not work without this, is community engagement and creating awareness and education in the community. And I will very briefly touch upon this before I end my presentation. For early detection, development of case definitions are very critical so that the cases will be identified for laboratory testing. Screening of suspected patients in healthcare facilities close to the outbreak area. What I mean by this is when we were in West Africa and I was deployed during the West African outbreak in Sierra Leone, we had a lot of healthcare workers, hundreds and hundreds, who were developing Ebola virus disease. And what happens for Ebola applies to Marburg. And when we started studying how these healthcare workers are actually getting the infection, we were surprised to see that most of these healthcare workers were not working in Ebola treatment units. They are healthcare workers in Ebola treatment units, but most of the healthcare workers that were infected were not working on Ebola treatment units. They were working on regular clinics, regular hospitals. Patients were just going to those hospitals and clinics, and without knowing that they had Ebola, they would come in contact with healthcare workers, and that's how they were becoming infected. So screening of suspected patients in other clinics, in all clinics and hospitals close to the outbreak area, and triaging patients is very, very critical. And lastly, prompt laboratory testing is important, as you can imagine, but laboratory testing closer to the outbreak area is more critical. Any delay from sending specimens from the outbreak area to central laboratories is a delay that would cause infections to spread. It would cost lives, and it would also waste limited resources by unnecessarily isolating patients that are not confirmed, but that may not actually have MVD. So laboratory testing close to the outbreak area as much as possible is very important. Rapid isolation, identify isolation areas ahead of time. And that isolation should be specific to MVD, not mixed up with other patients, with restricted access to families, even healthcare workers. So restricting access is very critical. And instituting what we call, unidirectional flow of personnel is very critical. And there is a specific guideline, as I said, on how to set up these isolation areas. The third is institution of appropriate infection control. You probably have already seen this in the management of MVD outbreaks. I have a list of the PPEs that are required, facial covering, goggles, mask, double glove, not single, but double glove, gown, and head cover, waterproof boots, basically covering healthcare workers from top to bottom is very, very important while taking care of MVD patients. If PPE supplies are limited, there should be a mechanism to prioritize how to use those limited PPEs. Now, if you can have all these PPEs, but if we're not using them properly, then it doesn't work. And we have seen and experienced this in the United States during the Ebola outbreak in West Africa. There were a number of healthcare workers who came back to the United States. Despite the fact that PPEs were used to treat some of those patients, healthcare workers in the United States got infected, even while using PPEs. For that reason, now we require that if there's a patient isolated and healthcare workers taking care of those patients, that doffing of the PPE should be carried out under observation. So we train people as observers. So their job is to stand at a corner and see the healthcare worker put on the PPE and also observe when the healthcare worker is actually putting off the PPE. So that observer is trained and also points out when there are errors for the healthcare worker, the way the healthcare worker is putting on and putting off the PPE. And that's become standard now in the United States.
Apologies for interrupting, Dr. Hermes. If you could try to wrap over the next 1 or 2 minutes, that would be great. I think we wanted to make sure we leave time at the end for Q&A. So if you could wrap, that would be wonderful.
Thank you, Tokwan. I'm almost done. Contact tracing, I would not spend a lot of time on this. Contact tracing, very critical. I would just point out that high-risk contacts need to be quarantined and closely monitored, even if laboratory testing has not been performed on those patients. Burial practices, handling of dead bodies should be minimized, and specialized bags, body bags, should be used to manage those dead bodies. Community awareness and education, as I said, is very critical. I would just highlight at the bottom is dedicated phone lines are very critical for healthcare workers to be notified of any suspected cases in the community. And those phone lines should be broadly advertised so that people in the community knows what to do when they have a suspected case. Finally, the reservoir. As you know, this is a picture of Rosetus egypticus. That's the natural reservoir of MVD. They shed the virus in saliva, urine, and feces. They are found throughout the African continent, so they're very common. They typically live in colonies, either in very large colonies, thousands and thousands of bats, usually in caves, and that's the picture you see on the top, or smaller colonies in 20 to 40 bats, and those colonies could be found in forested areas. They prefer to roost in dark areas, but people coming into contact with them, they usually walk into caves or work in forested areas. And we actually had a colony at CDC of bats to study the natural history or the natural progression of Marburg virus disease, and we know a lot about how the virus actually behaves in the natural reservoir. And these are the resources that I mentioned, and I will open it to question and answers. I don't know, Takwam, how you want to handle this.
Thank you so much, Dr. Hermes, for those insights, and that was really informative. We'll have time for Q&A at the end. If that's okay, I'll move us to the next section, building sort of on that global experience and now focusing a little bit more on Ethiopia. So Dr. Hermes, if you can hang on and wait, we'll take questions at the end. Audience, thank you again for hanging on. It seems like a very active chat. Thanks for the engagement. As some of you may know, Ethiopia has made important investments in public health infrastructure and emergency response capacity. But as you heard, Marburg virus disease presents unique challenges that also demand a very highly coordinated and multidisciplinary workforce. So this next section will be structured in two parts. First, focusing specifically on Marburg virus disease response readiness, and then broadening the lens to at workforce preparedness beyond Marburg, including cross-cutting gaps and future needs. So our first speaker on this next session will focus on the current state of workforce readiness for Marburg virus disease response in Ethiopia, including preparedness response efforts across key response functions. It is now my pleasure to introduce Dr. Melkamu Abte. He's the Deputy General at the Ethiopian Public Health Institute. And in his role, he leads the Public Health Emergency Management Wing and has also been leading the Marburg virus disease response preparedness and response efforts in Ethiopia. I'll just note for the audience that all of the speakers have incredible experience. In the interest of time, I'm just keeping it brief, but I'm sure more information will be provided to you later on if you want to learn more about the work they have done throughout their careers. So, Melkamu, whenever you're ready, the floor is yours.
So much, Dr. Takwa. Is that visible?
Yes, if you can do, yeah, perfect.
Okay. Thank you so much for those of you joining us online and for moderating this, Dr. Taqam. I really appreciate it. So I'll be very brief and I'll go through on the public health aspect and on the practical session what is really happening on the ground. So I will show you mainly on this on the multidisciplinary emergency workforce readiness, specifically for this Marburg outbreak, the Ethiopia's practical experience on the ground. As you all know, we have declared this Marburg outbreak in Ethiopia on November 14. That is declared by Her Excellency our Minister, and following the declaration of this outbreak, we have initiated the national task force being activated, and the IMS is activated down there. So the activities were not started by the declaration, but as there were reports in Rwanda, we have started the preparedness activities during that period as well. So we have high population mobility in the country. Bullies have for Africa, so we were at risk of having this kind of disease, so that we have started the preparedness activities before the declaration of this MVD here in Ethiopia. So the task force, the IMS, and the different platforms were activated. So considering all this, all the epidemiological risk and the high risk of the regions, we have mapped South Ethiopia, Sidama, and Central for the close proximity to this Jinka. The epidemiological summary is this one. So as you remember, we have 14 confirmed cases, and the total deaths were 9, and the case fatality is 64. The total recovered from this disease is 5. So we are now counting days to declare that the country is out of this Marburg disease. We are now on the 31st days of their reporting from the last case, which has been reported from Dasanich. So this is the epidemiological summary, and the global aspect and the general aspect of the disease has been mentioned by Dr. Ermias earlier. So I will speak on the role of the workforce, as I mentioned earlier. Be it the task force, be it the IMS, be it the different pillars that we were managing, the surveillance, the laboratory, the case management, the risk communication, the community engagement pillars are going to be implemented by the workforce that we have. So every activity is going to be done by the workforce, so that I will show you the role of workforce for this Marburg outbreak response. So this plays a decisive role in the outbreak response by enabling rapid detection, risk communication, and community engagement to the community, and for the containment. So the key story comes from where coordination at the national response is swiftly implemented and going down synergized with that of the regions. So as you all know, there are different workforce capacities that we're building from the past different years. We have the field epidemiology training program, the AVOC search program, the FEM training programs, the Ethiopian Health Emergency Corps programs. These are few of them that we are implementing in the country. By this, we are able to uplift our workforce capacity, and there are different programs that we are implementing at the community level and at the facility level. One is a community initiated public health emergency management program, and the other is the FEMA health facility program. By that means where every health facility has to be ready to detect and to respond to any kind of emergencies which are happening down there. So the first detection of this Marburg case has been done in that lab. So we were having the FEM focal persons at the hospitals. They were observing a cluster of cases presented with this viral hemorrhagic symptoms. So that was the alert case. So that we're observing that cluster of cases, and we can make it the early detection and the management. So here I want to express that our preparedness efforts were really paid off. So preparedness is critically important than that of the response activities. So this preparedness efforts has been started earlier. And this is what the workforce is trained, and that enabled us to have this early detection and reporting, which I mentioned earlier. That is a practical example that we were detected at Jinka Hospital. So that is a good thing. This allowed us to have this faster surveillance and reduce delays in response. By this, we were able to decrease the community transmission and other problems. So the other importance is the multi-sectoral coordination. These national response teams are integrated. One is they are integrated in coordination, starting from the community up to that of the national level. And the other thing, there is a mix of health professionals were deployed. So the epidemiologists were there, laboratory technicians, and even the local leaders in the veterinary side were implemented. This is a unified implementation approach, starting from the community to that of the national level. So this kind of workforce arrangement that we have were enabled us to avoid duplication and improve efficiency among the national and subnational teams. The other one is the risk communication and the community engagement aspect. As you all know, there are such kind of reports when emergencies happened. The emergencies are new. There are low awareness in the community, and even resistance has been happening there. But because of the workforces that we have trained, and they go down to the community, and they were able to teach. By that, we're having a trusted presence at the community, which enable us to make the isolation measures, the quarantine activities, the early reporting. All those things can be possible, and even at last we are able to give vaccines and medications to those who are in need. And the other is the clinical care and infection control. We have this emergency medical team roster, and health professionals who have trained on this supportive treatment, on the protocols. So we are able to deploy them timely, so that we as you have seen, we have about 5 recoveries. As to the recoveries, one thing that we have seen practical is when the cases were presented themselves earlier, who were getting the proper care, they were discharged, they were recovered. So one of the things that we see is early visiting this health facilities is one of the critical milestones that led the different cases to recover. So what I have learned is this swift response. Within a day of confirmation, Ethiopia deployed surveillance platforms, trained staffs, and set up a pandemic task force and incident management system. So this is the first thing that we did on this Marburg response. So the surveillance team was deployed down there. we were able to make the different platforms, starting from the community to that of the national level. And training staffs, multidisciplinary training staffs were deployed, trained staffs were deployed. So by this is rapid mobilization, limited cluster of cases and prevented community-wide transmission. So all the cases that we got, it is on a single chain. There is no community transmission. And the other point that we did is we were using this One Health approach. So a multi-sectoral, multidisciplinary team was deployed, and they are investigating on the causes of the index case, where the index case acquires the infection. That investigation is undergoing. So having this multi-sectoral, multidisciplinary team is really one of the important things that we get. And we are able to keep the standard and the guidance of the global and national protocol. By this, we were aligning with subnational and the visible workforce presence down on the community and at subnational level. And there is an alignment and trust between subnational and national IMS. So this ensures that the health measures and this reduces the misinformation. If you remember that when these outbreaks were happening, there are different information flowing from different sources. So by aligning with the global and these national protocols with that of the subnational team, the coordination made us to reduce this misinformation, and we are better respond. And the other is active community engagement. The community was at the end of at the corner of this response. So in terms of isolating individuals who have their contact, following them. So, and also the community were at the center in protecting themselves. So that one of the things is to make an active community engagement. And the other important point that we learned is continuous adaptation and learning from not only from the global experience. We are learning from our practice as well. We are now looking at our practices and then adapting and learning every day will make us efficient. And the final point is that I want to speak is Ethiopia's Marburg outbreak response underscores that there has to be strong, trained and trusted workforce, which is the backbone of this outbreak response. So rapid mobilization, as per the recommendation of WHO, we are able to down there at Jinka within 24 hours, and we use this multi-sectoral coordination, and the community engagement will lead us to efficiently control, and we're on the verge of declaring this one. We are counting the days. So these all things will make us to be effective. Maybe this point is critically important. Rather than investing on response things, preparedness is a strategic investment in terms of financial mortality and that of morbidity. We need to work on this, and we need to build our workforce in this way. And we can say that in Ethiopia's experience, our previous investment has really paid us. Thank you so much.
Wonderful. Thank you so much, Dr. Malkamo, for that really grounded and practical overview of the MVD response in Ethiopia, and particularly talking about sort of the workforce capacity and the role of community members. Hang on, we'll take questions at the end, and I've seen some come through. In the interest of time, I'll move us along. Our second speaker on this topic will take a wider view. So examining workforce readiness beyond MVD and highlighting sort of cross-cutting gaps that affect preparedness for a range of public health threats. I am pleased to introduce Dr. Salamon Beza Wargo. He's the regional director at Ohio State Global One Health LLC. His expertise spans the design of health system policies and strategies with a strong focus on human resources for health and maternal and child health. Dr. Salamon, the floor is yours.
Thank you so much, Dr. Topan. Can you hear me?
Yep.
Oh, wonderful. So, well, my job is much easier now because Dr. Malkamo has touched a little upon on health workforce preparedness, how effective was the country in terms of deploying the most important health workforce in responding to this Marburg outbreak. So I'll walk you through all that. Yes, this is the outline of my presentation. So, I'll touch upon a little bit on what are we referring when we say health workforce in response to Marburg outbreak. How should the number and health workforce mix like for us to be effectively respond to this outbreak? And I'll touch upon a little bit on the efforts in terms of preparing the workforce for the response, and also take you through the most important recommendations globally, particularly by WHO, in terms of how countries prepare their health workforce for effective response when it comes to viral hemorrhagic fever, and then briefly touch upon on the lessons that we can draw and the key takeaways. So, health workforce for this outbreak, for Marburg outbreak, refers to the outbreak response team. So, according to WHO incident management system and the guideline by African CDC, both recommend what kind of models countries need to have for the outbreak response, which is suitable for low middle-income countries in response to viral hemorrhagic fever. So, the response team is comprised of 7 groups, and according to African CDC and WHO, it comprises of incident management and coordination team, which includes incident managers, operation leaders, planning leaders, logistic leaders, finance, and safety officers. These individuals are responsible for command and accountability and overall coordination. So these are some of the numbers for the national response, okay? It probably requires total of 15 people. So when I do this presentation, one of the things that I want us to do is reflect back on in terms of, how was our organization like in terms of preparing the number and the skill mix for this outbreak response. And the second group of response team comprises of surveillance and epidemiology team, which includes field epidemiologists, surveillance officers, contact tracers. A nation might need close to 25 to 40 people for us to be able to find every case, trace every contact, for us to be able to stop the transmission. A third group is the case management clinical care, and this is obvious. It includes physicians, nurses, pharmacists, emergency physicians, or critical care physicians. A country, if this outbreak gets at a full scale and affects all the country, we probably need to have 70 people ready on the field. The fourth response team is a laboratory and diagnostics. This includes virologists, molecular lab technologists, sample transport officers, biosafety officers. The fifth group is the infection prevention and control team, which are responsible to protect the health workers and, of course, prevent hospital outbreaks as well. These includes IPC specialists, nurses, environmental health people. And the sixth groups are risk communication and community engagement people. These are also very critical in terms of stopping rumors, because our community engagement is also one of the most important things when it comes to stopping an outbreak, because the people need to be engaged, because at the end of the day, unless we do a lot in a community, at the end of the day, we're not going to be successful in whatever outbreak response we're planning to do. And the seventh and the most important, and I would say not I would say, equally important is the logistic and security support system. This includes individuals in the supply chain, the PPE coordinators, and the security. Oftentimes, they might be forgotten because we focus so much on the incident management, the surveillance, the epidemiology, and case management and lab. We forget how important these logistic people are, because at the end of the day, we need to have those PPE and IPC materials on the ground to protect patients and providers as well. So, having said that, yes, this country, as Dr. Malkamo has mentioned earlier, we have an ongoing efforts in terms of preparing health workforce for outbreaks, for outbreaks in the country, and of course, pandemic. We have a field epidemiology program in this country. We have a FAME training program. We have FAME focal persons at health facilities. Even then, that was not enough in terms of equipping health workforce for them to be able to respond to these outbreaks. That's why we had to do series of training, both face-to-face and virtual, identifying those important health workforce for them to be able to effectively contain the infection. Just to give you a brief highlight in terms of what trainings have been provided by EPHI in partnership with partners like CDC and including Global One Health at Ohio University, includes training on surveillance and contact tracing, training on preparedness and response for RRT team, training on infection prevention and control, and proper use of PPE, and case definition, case management, including through digital platform, specimen collection and management for lab technologists, and PCR testing. These are, and I must have listed a little more, but these are some that I'm aware of. And for sure, there could be other trainings which have been done by other partners as well. So, and overall, I think Dr. Malkamo has mentioned earlier, this country has done an immense job in terms of containing the virus, in terms of getting on top of the response through deploying health workforce and being there in 24 hours. But we also have seen a little bit gaps for us to improve whenever other outbreaks emerge. The first one is, we should have had all these people ready for the outbreak response team. Not only the preparation should not only focus for FAME people or for field epidemiologists, but also for healthcare providers in the country, including clinicians, nurses working in a hospital, particularly managing, and every public health professional in the country as well. Because when outbreaks hit, it requires the engagement of everybody in the country, everybody in the health sector. It's not enough that we do train and prepare the FAME people. It's not enough that we have field epidemiologists on the ground, but we need to have every healthcare provider ready for us to be able to contain this infection as early as possible. For that to happen, I think one of the things we probably have done better is, I'll speak to this later in my next slides, is getting everybody ready for outbreak response. This has to be part of the competency of every healthcare professionals in the country. The other is maybe in terms of coordination. Yes, we get there as early as possible, but has everybody know his job, his role, his responsibility in terms of doing this thing right, is also an issue that we probably need to reconsider and doing it even better. So globally, this is what WHO recommends in terms of preparing health workforce for outbreak. Yes, response is not enough. We need to do a lot in preparation as opposed to response for outbreaks. But outbreaks would always be there. Even if we make all the preparations, the response is not something that we can be exempted from. We can do immense in terms of doing the preparatory work, but how can we do the response even effectively when it comes to preparing health workforce? The first one is, we need to have a workforce clear planning and surge capacity for us to ensure enough trained personnel, available across the country. How do we do that? we need to have a registry. I think we have a very good experience, an ample experience during COVID time. We tried to do this, having a national health workforce register in case if this outbreak goes out of control, if it requires a lot of deploying a lot of health workforce, we should be able to have that national health workforce registry for us to get people from there. The second one is we need to also develop what's called a surge staffing plan. We need to do task shifting, redeployment, and even emergency hiring. Thank God that has never happened because it's the outbreak is not as big as we thought. It was already contained in the southern part of the country. But if it ever happened to involve across the country, these are some of the actions that we should have even taken. And create a reserve team which is trained and ready for deployment is another. Having an agreement with private sector and NGOs, because those are also key important parts that we need to engage in outbreaks, because they also have a good number of quality and quantity health workforce. The other is WHO recommends on having education and training to equip health workers with outbreak-specific skills on IPC, use of PPE, case definition, triage, isolation, specimen collection, laboratory safety, and whatever. And this training is not enough. I'm talking about education. How are we doing this in a pre-service education setting? How much dose of public health emergency management do our health profession education covers? This is also one of the things that we should be able to ask ourselves. Do we have everybody ready upon graduation? Do we have did all our health workforces have the competency they need to be able to manage emergencies and outbreaks and upon entry into practice? Or do they require training all the time? Is also one of the things that we need to discuss. The methods could be regular simulations, exercise, and drills. How frequent do we do drills, for us to be able to prepare for outbreaks? Yes, we have trained individuals, but drills are also equally important, assuming, creating those scenarios, thinking that outbreaks can hit anytime. So prepared health workforce is also important. I can't emphasize on the importance of e-learning platforms, because at times there is no time for us to do face-to-face learning. So for us to reach all healthcare providers as quick as possible is using e-courses. And we've tried that, fortunately, in this outbreak response. And on the job mentoring could also be another approach. So through this process, we don't have to also forget the wellness of our healthcare providers. This is a very, very stressful time. So we need this health workforce after the outbreak. So their safety and wellness also matter. So ensuring access to PPE and vaccine, their mental health is also very, very important. And then Dr. Marcamo has mentioned a little bit about the learning part, post-outbreak learning. This is the right time once we declare, the control in this country of Marburg is no more an issue in this country. One of the things that we should do is we need to sit down and do what is called an after-action reviews. What have we done better? Is there anything that we should have done even better? Okay, is there any protocol and training that we should update? How are we going to invest in terms of long-term workforce education retention? How can we strengthen our public health capacity is also another thing that we should talk about. And 2 more slides to go. And then another important thing we need to consider is the communication and information system to give information to the health workforce in a timely and accurate manner is also important, because at times the source of rumors and misinformation could be the providers themselves. So unless we provide them with the right information, they could negatively affect our response efforts as well. And then these are my takeaways. So this is moving forward. I think we're starting counting down, as Dr. Malcamo mentioned. Then this might be the right time for us, once we declare it, and sit down and go through, asking ourselves, how much of whatever we have done it successfully? So this needs data. So we should be able to gather data in terms of that helps us guide us doing much better in the future outbreaks. The other thing is the use of digital technology for training and information. This is also another thing that I would like to emphasize on. Equally important is strengthening the pre-service education for public health emergency and engaging health professionals on continuous education. Before any outbreak happens, we need to continuously engage on issues related to global health security, because outbreaks will always be there. So we need to continuously engage our health workforce, prepare them for the next outbreaks. And finally, let's not overlook the mental health issue of professionals. By the way, I would like to take this opportunity to thank all those healthcare providers who were on the front, sacrificing their lives for us to stay alive and contain the outbreak. Over, Dr. Taqwa.
Wonderful. Thank you so much, Dr. Salamon, for those really important insights. I think it's clear that workforce readiness is not just about the numbers, but about the skills, coordination, and sustainability, and you articulated that really well. So this naturally brings us to the role of partners in emergency response. As you know, no country responds to outbreaks alone, and effective emergency response depends on strong partnerships across government, international agencies, NGOs, academic institutions, and communities, as Dr. Malcolm mentioned earlier. And now I'm pleased to welcome Professor Wendosen Gabriels. He's the president of Global One Health LLC and One Health Global Alliance. He's also a Hazel C. Youngberg Distinguished Professor at the Ohio State University and has been actively engaged in innovative global health system strengthening using the One Health model. He will speak to the role of partners supporting workforce readiness and emergency response for MVD and other public health threats. And now I'll turn it over to you, Dr. Wendosen.
All right, thank you so much, Dr. Taqwa. Thank you, everyone. Thank you, APHC Ethiopia, and all the partners and participants. Great to be here. I will be brief in the interest of time. I will have 7 or 8 slides. All the former speakers, which I learned a lot, quite a bit from all of them, really emphasized one way or another, directly or indirectly, how important the role of partnership is. So I'll give few points from the standpoint of our experience, my experience, mainly working across the globe under our umbrella alliance, the Global One Solutions One Global Alliance, which Dr. Taqwa is one of the key leaders and co-founders. So you can hear me okay, I am sure, and I'm trying to change my slide now. Oh. Okay. Yeah, so quickly looking at the global landscape, really there is always a shift in global dynamics from many different points of view: man-made, political, socio-economics, ecosystem, population is growing, urbanization, the intensity of diseases, human diseases as the interface of animal health, plant health, environment has become so dynamic. More and more emerging diseases are complex, which we collectively call wicked problems. So MVD, Marburg virus disease, is one of the many, right? As the keynote speaker highlighted, the zoonotic, emerging, re-emerging infectious diseases or antimicrobial resistance, all of them are complex issues that necessitate, as Dr. Marcamo earlier said, a multi-sectoral engagement, which is key and essential. So working beyond our typical classical organizational silos is critical, and that's what One Health emphasizes. That's what all these problems, including such this outbreak, that Ethiopian government and all the partners are responding swiftly, is teaching us, has taught us, as well as recent pandemic, as well as Ebola and many other issues. So one is dimension, as it's been mentioned, cannot be achieved without partnership. Partnership is crucial. Transdisciplinary partnership, multi-sectoral or trans-sectoral partnership, as well as transboundary partnership in the geographic sense is so critical. The global One Health, the One Health dynamics in general at the global scale, global, geographic, or global in a holistic, multi-sectoral, transdisciplinary manner, as it indicated in this diagram. This is from the United Nations quadripartite One Health expert panel. It's so complex, right? So often, majority of the emerging diseases amplify in an animal population, including now the Egyptian fruit bats, before they spill over to humans and becoming so costly in terms of lives lost, in terms of economics, tourism, and many other dimensions. Prevention is really the critical part that we would like to focus. It's much more cost effective, saves lives, saves economies, and so many. However, there is always, we cannot be 100% proof by prevention. So there is always be preparedness. And when outbreaks such as Marburg virus disease occur, we respond. So building capacity in the various areas, laboratory capacity, surveillance capacity, the healthcare workforce capacity that we are discussing today, and many other areas are so critical. It's one of the many critical areas that Ethiopia, many developing countries critically need. And it's been really great. I would like to take this opportunity to thank Ethiopian government, particularly Ethiopian Public Health Institute, Armor Hansa Research Institute, Ministry of Health, Ministry of Agriculture, Environment, other many sectors that we have been partnering with. So it's been really great. But our goal is so far reaching, so much problems. So I think partnership, synergistic work is critical to make success. So in this MVD response, our key units, Global One Health LLC, that Taqwa mentioned, has played great role. Our team, including Solomon, Dr. Solomon is the strategic director, many of our other directors, as well as many people on the ground, experts from our team, worked collaboratively to support Ethiopian government's response. These are the list of things on the left-hand side in terms of rapid outbreak response. We've been working on surveillance capacity building, other partnership, particularly with EPHI and regional health bureaus, but with CDC as a key sponsoring agency over the years. For the last at least 10 years, Dr. Ermias has been critical in the first cycle of global security when we started partnering, supporting Ethiopian government starting around 2016-17, using rabies as a model, using brucellosis, using antimicrobial resistance. Those activities we set the ground led to the COVID-19 response, IHR, others implementation, lab capacity building, molecular diagnostics, PCR. Very delighted to see now with this Marburg virus disease response, Ethiopia is able to rapidly detect, do wonderful real-time PCR through such partnerships. Rather than, all of you remember when SARS-CoV-2 hit, samples were being sent to South Africa, others. So, building that internal capacity through a synergistic, effective partnership is critical. Training has been mentioned together with our team, with EPHI, CDC, regional health bureaus. At this moment, right now, I'm sitting in Hawassa, one of the places, but definitely in South Ethiopia, Jinka or Arba, Mincholaita, all that training that jointly being done has been really necessitated great partnership. Provisions of PPE, supplies, infection prevention control, joint trainings, all have been really, again, underscores the critical need of partnership. RCC has been mentioned, the community engagement, communications, risk communication parts. We started even engaging local NGOs, including I was visiting earlier today here, the Mary Joy community engagement. We were able to see, I and Dr. Taqwa were able to see at Hawassa, the poster showing MVD in Amharic and the pictures that community can easily understand and take precautions measures as it's been outlined. So all of this require partnerships, which is really fantastic. So our organization, couple of slides to finish, our mission, the One Health Global Alliance, beyond the Global One Health LLC that's functioning in Ethiopia, is to be the catalyst for such partnership, an on-demand global catalyst, bridging the gap between the global north and the global south, equipping professionals, institutions through collaboration, consultative activities, co-creation, and capacity building, as we have been doing in the past. And we've been in Ethiopia at least since 2011. We've been really bringing global partners for outreach and partnerships. That has been so critical. So yeah, I hope we'll have time to discuss, but I think our world is at an inflection point. One Health is needed more than ever, and look forward a very synergistic and effective partnership in Ethiopia, in Africa, and beyond to make impactful contributions. I'll stop there, Dr. Taqwam. Thank you.
Wonderful. Thank you so much, Professor Wonderson, for highlighting the importance of collaboration and particularly during emergency response efforts. So we'll now move on to our Q&A session. And thanks to everyone who's already submitted questions. I'll start with a few questions that I've seen come through earlier. And I think I'll direct specific questions to particular speakers. So first up, Dr. Ermias, there is a question for you. And it reads, can breastfeeding mother transmit to her child? If yes, do we have scientific evidence?
Thank you. The short answer is yes. Do we have scientific evidence? Yes. So the virus has been isolated in breast milk a number of times. As I indicated in my presentation, all bodily fluids that come out of an infected person are potentially infectious, and because the virus has been isolated from those bodily fluids, and specifically from milk, and pregnant lady or nursing mothers who are infected are actually not recommended to continue breastfeeding at the time when they are symptomatic.
Great, thank you. And for Dr. Malkamu, see a question that reads, what is the next priority plan or measure to be taken to prevent a relapse or resurgence of the outbreak, considering that the virus can persist in body fluids of recovered individuals for an extended period of time? I'd like to take this.
Thank you so much, Dr. Taqwam. So the next priorities are one is we are going to follow the survivors. We'll follow them serologically and clinically in different ways. So that is one thing. The other point that we are going to do is this can happen again. So for that, we'll shape our workforce and the entire health system architecture to detect and to respond for such kind of outbreaks, not only for Marburg but also for other viral hemorrhagic fever causing diseases. And the other point is we'll shape our this communication based on a One Health approach. We'll use One Health approach to shape the interaction between human-animal interaction and human-human interaction. We'll shape our risk communication in that line. Thank you so much.
Thank you so much, Dr. Malkamu. And I think in the order of presentations, I will direct the next question to Dr. Salamon. And you've touched on this a little bit, but if you could expand on if you had to prioritize one or two workforce-related actions over the next year, what would they be and why?
Very tough question. Yes. So I think Dr. Malkamu has touched a little on that, because this outbreak is going to come again. We're not, like, it's not a guarantee that we're not going to face any other outbreak. So the priority has to be, having preparing a workforce and a pre-service education setup being in the horizon. We need to continuously engage the health workforce on a short training or sort of webinar like this on global health security issues. So now we need to begin, talking about, okay, what would be this next outbreak going to happen, and how should the health workforce be ready for that? So, fortunately, the principles for all outbreaks, including viral hemorrhagic outbreaks, are the same, especially in terms of PPE and IPC and the importance of early detection and isolation. So, these are all, similar for almost all outbreaks. So, but yet again, time and again, we fail to do this. We still lose health workforce, especially because they're the ones who are going to face the first cases. So, knowing that on continuous basis, once we recognize now that there's going to be another outbreak coming, I don't know which one is going to be. So preparing the health workforce and a sort of webinar on short courses on how to prevent, the use of PPE and IPC, early detection and surveillance is critical. So that is going to be my top priority.
Wonderful. Thank you so much, Dr. Salamon. And now, Professor Wendosen, if you could answer, how can partners align their technical and financial support to avoid duplication and ensure sustainability of workforce capacities beyond the immediate response?
Yeah, thank you so much. That's very, very important, especially as resources are becoming more and more limited. More needed, but it's becoming more limited. The global dynamics of healthcare financing in general, the trend as we know it is not that positive. So we need to be creative. We need to create synergistic measures. I think for that to happen, effective communication and partnership, engaging who is doing what, convening through maybe, if it is like in this case, Ethiopia, but it could be another country. It could be Kenya, it could be Nigeria. I know there are some participants from different countries. But that kind of engagement convened by the primary stakeholder, which is the government of the country, engaging partners and knowing who is doing what, where resources are being focused, so that to avoid redundancy would be critical. Secondly, I think I cannot underscore enough, focusing on prevention aspects would be so critical, right? So more and more resources towards prevention and preparedness would be so critical. So minimizing the chance of occurrence of such outbreaks through various means without duplicating efforts, creating a synergy, I think would be critical.
Great. Thank you so much, Professor Wendosen. No, we have 1 more minute. So if I may quickly come back to Dr. Ermias, and if you could keep your responses down to 60 seconds. I see a question that reads, do all health facilities need to have an isolation space within their premise, even if they do not manage MVD cases?
Those facilities should have a plan on how to handle a suspected case of MVD. But isolation and management of patients ideally should be done in a specialized area, designed specifically for handling MVD patients. And these facilities do not have to be fancy buildings. It could be done in a tent, for example, as long as the appropriate infection control measures and patient management procedures are in place. So facilities should know where to refer patients that are set up specifically for handling, isolating, and managing MVD patients. They should have a plan, but they don't have to necessarily treat the patients.
Great. Thank you so much, Dr. Ermias. I think we're coming up on time, and unfortunately, we won't be able to get to every question, but truly appreciate the level of engagement. And we'll try to see if we can get responses to you in written form as appropriate from our speakers. I would like to thank all of our speakers for sharing their expertise and our participants for such thoughtful questions. Today's conversation reinforces a key message. Strengthening multidisciplinary healthcare workforce is central to preventing, detecting, and responding to MVD and other emerging threats. We hope that you leave this webinar with some practical insights, renewed partnerships, and a shared commitment to preparedness. Thank you again for joining us, and we look forward to continuing similar discussions. It was my pleasure to moderate this, and wish you all a wonderful rest of your day.
Thank you.
Thank you so much.
Thank you.
Thank you
so
for
much.
keeping us on time.
Yeah, great. Thank you.
Thank you.